I'll be talking about how we do global health research at the University of Washington at this place called the Institute for Health Metrics and Evaluation, which is a real mouthful, so we just call it IHME. And first I'll just tell you a bit about what we do here at IHME. So it's an independent research center at the UW. We got core funding from the Bill and Melinda Gates Foundation about 8 years ago, so it was a $100 million grant to start it. And we have, right now we're up to almost 250 people, a combination of faculty, researchers, staff, a lot of students as well. And our goal is to provide a rigorous scientific measurement of all the world's health problems. So it's a very broad goal, but the idea started that the Gates Foundation and a lot of other funders like themselves, as well as governments, wanted to have a better idea of where's the best place to spend your money, because where are the problems the biggest? What are the costs of different things? What are the efficacies of those things? And use that to help decide what's the most efficient use of resources in order to improve the world's health. And so IHME, our role is to help take all the data that's out there and synthesize it into a more coherent and complete picture to make those decisions. So the big project we work on that takes up a lot of the resources and time at IHME is called the Global Burden of Disease. And the goal of this is to make a picture of what is killing people, what is disabling people, what are the major risk factors across the world. So we do it for every single country. We've done it from 1990 through 2015. And for over 300 diseases and conditions and injuries, which encompass basically every way a person could get disabled or die. Disabled or die. And then we do it by age, by sex. We attribute those to risk factors. And what we end up with is something like that picture you see on the right there. That's a tree map that shows you what is the disease burden in DALYs. This is disability adjusted life years, which is how much healthy life is lost due to different conditions. I believe this is for 2013 for the world. So you can see the red over there is the communicable diseases. So you've got LRI is lower respiratory infections. So those are pneumonias that kill a lot of children as well as older adults. You have diarrheal diseases, which is also mostly young kids. You have HIV and tuberculosis and malaria. Down at the bottom in the green, you've got injuries. You can see the biggest portion there is road traffic injuries, but there's also a lot from violence, such as wars and disasters. And then in the blue, we've got non-communicable diseases, the largest of which is ischemic heart disease. But we also have stroke on there. There's a big cluster in the middle there for all the different types of cancers. And so the goal is just to come up with what is the major cause of disease here, and then we want to look at it globally as well and see what are the patterns here. So this is if you take the death rate for 2013 and you take the age standardized rate, you can see that it's just vastly how different it is. The scale's not showing up here, but it's just much, much higher in sub-Saharan Africa than it is just about anywhere else. There are parts of South Asia that are relatively similar there. And then if we look at the childhood death rate, so that's just children under 5, the picture is even more stark, which is that most developed countries in Western Europe, Latin America, North America have had huge gains over the past 100 years in reducing child mortality, but still parts of sub-Saharan Africa are lagging far behind. And to further illustrate the difference between those countries, types of countries, if we look at the DALYs, again that's the deaths and disabilities, the proportion of them in developed countries, you can see, is almost entirely blue. That means that's almost entirely these non-communicable diseases, such as cancers, diabetes, heart disease, where then if we instead look at it in developing countries, it's this red block is taking up a substantial portion of the picture now, with again those things like pneumonias and diarrhea taking up a huge portion of the burden. And these are things that we all know how to solve. It's just figuring out how to deliver the appropriate resources in order to do that. But as you've seen in the developed countries, we already have proven ways to reduce those. And in order to do this, we have a collaborator network of over 1,000 people in over 100 different countries, collecting this information, running statistical models, evaluating the results, writing papers on it. So this is not just something at the University of Washington, this is really a global effort. So that's the biggest thing that we do at IHME. Another one is called the Disease Control Priorities. And this is a collection of projects that is trying to assess the costs, effectiveness, and access to healthcare around the world. So we want to say, how much does it cost for a certain type of treatment? How effective is that treatment? And where can people get that, or where is it lacking? And the idea is that policymakers can use that information to assess where should they put their limited resources to save lives. And so as you can imagine, the goal is to be able to combine this with the global burden of disease information such that international donors can decide where they could have the biggest bang for their buck in terms of saving lives. So that's what IHME does. And I'll get a bit into why we use Python so much there. In the scientific computing group, we've got over a 20,000 core SunGrid engine cluster that we use. And now we're using Spark, where we've got a 1,000 core cluster that we've just started up and are beginning to transition to. We have over 50,000 input data sets, which fortunately for you are almost all online and publicly accessible. If you just Google GHDX, that's the Global Health Data Exchange. We've got the largest collection in the world from all over the world in terms of death registry data, verbal autopsies, which is where you go to door to door and you ask, has anyone died here and what were their symptoms? We have a whole set of information on that, which you can use for some pretty cool machine learning testing to figure out, if you have good classification algorithms. And we have a gold standard data set for that you can use. And then we have lots of our different modeled outputs as well as information on costs and really just about anything you want, and it's nice and labeled and easy for you to get. We produce a lot of data. We make every time we run the GBD, it produces over 25 terabytes of data. And for some of our new projects, we're pushing over a petabyte every time we run them. And I'll get a little into those later. And then we have interactive data visualization. So all those graphs I showed you are actually from an online tool that you can use to browse our data set and view it all with little D3 visualizations we made. So why do we use Python for all that? A big part of it is just that it's free and open source software, as well as most of the packages. And that's great for us because we're a nonprofit and we don't want to have to spend more on software than necessary. But it's even more important for our collaborators. We're working with people all over the world who need access to the software we produce. And it's, just having any sort of department devoted towards statistical sciences in these places is often a stretch. So being able to shell out a few $1,000s for Stata or something is kind of out of the question. So that's a big part of it. Also is just the ease of use. One interesting thing about IHME is, although so much of what we do is data science, there's not that many actual trained statisticians and computer scientists there. We have a lot of epidemiologists, we have a lot of medical doctors, and people who come from the social sciences who do not necessarily have as much experience with coding. And so something they can pick up relatively simply is great, and especially with IPython notebooks. That's something that we found is just wonderful for helping them figure out a workflow for coding. Rapid prototyping is a big deal for us. We try out lots and lots of models with all our different research projects, and the fact that we can just get a package fairly simply for most of the cutting edge statistical techniques out there makes it really appealing for us, as opposed to waiting for, when we used to do Stata, waiting for them to come out with some of these new mixed effects models or something like that, and waiting years in many cases. And extensibility, just that we can keep adding more and more things to these modules and sort of pushing the boundaries on new methods and integrating them. And probably the biggest advantage for us most recently has been the scalability of Python. Now that we're using it with things like PySpark, and we're rewriting a lot of the backends for our stuff in C++, but being able to run it from Python makes it so that our 20,000 core cluster isn't as busy as it used to be, which is great, but we can still run these gigantic models, which I'll talk about in a bit, relatively quickly. And then lastly, interoperability. We basically use Python as the glue at IHME in that we have lots and lots of legacy code, in a lot of it in Stata or SPSS or R or more esoteric things. Going back to the fact that econometrics departments used to use Stata a lot, which then meant the World Bank used Stata a lot in the mid-90s, which meant the World Health Organization did, which meant we did. And so we have 20-year-old code that not all of it we've gotten around to updating it, but we can still call it from Python or load in old data sets that were created in Stata 20 years ago, update those a little bit and then use the pandas to read in the later versions. So it just has made it so that we can tie all our stuff together into a single, sometimes rickety, but at least a single framework. So I'll talk a little bit about a couple different kinds of models and statistical techniques we use at IHME. The first of which is going to be our big ensembling model platform, which we use for estimating causes of death. As you can imagine, cause of death is sort of the biggest headline number that a lot of people look at when trying to assess the state of a country's health or trying to decide where to spend money. It's, I want to save lives, which means I want to prevent people from dying due to certain things. So the goal of CODEM, which is the cause of death ensemble model, is to figure out what kills who and where. And that's actually a much harder problem than you might expect. A lot of places don't have any sort of death certificate system. In the US, you can just go and request anyone's death certificate and find out exactly why they died, though even that relies on the doctor noting it correctly, but at least there's some information there. But in a lot of countries, that just doesn't exist. And we have all sorts of different survey methods. We have little sampling systems. And in a lot of places, we just don't have any information whatsoever. So we want to come up with a complete time series. Every country in the world, every cause of death, over time, by age and sex, what's killing people. So part of it is filling in all that. And then the other thing we have to deal with is there's a huge amount of debate about what is the best modeling strategy for this. There's, probably, if there's 100 experts on it, there's 101 different ideas on the best way to do it. And so, especially since we have that huge collaborator network and we want to be able to integrate everyone's different ideas in this, we've hit upon a sort of an ensemble strategy to combine all these different approaches, selectively evaluate them, pick which ones work the best, and combine them into an ensemble that sort of pleases everyone, that their model got a shot at producing the estimates. And if it didn't perform as well in cross-validation, then that's why it wasn't chosen. So to give you an example, here's ischemic heart disease, so that's dying of a heart attack effectively, or its after effects in Russia in 65 to 69-year-olds. So this is what our data looks like, and this is a place where we have fairly complete time series. And now we want to create a model of this. The standard methods that we often see is first you just fit some sort of linear regression. You have different covariates. You say, we know what the blood pressure is from different measurements. We know what the alcohol consumption. We know about the cigarette consumption. We know something about the diet. Use those to make a prediction of these levels. And that will often get you something, but it's not necessarily very close. So the dots are the data there. And just a simple linear regression with covariates is that blue line. And then we use some methods that take the residual information there and try to smooth it over time and space for where we do have data and get a better picture that doesn't just look at the covariates, but like what do neighboring countries look like, what do other neighboring age groups look like, and that'll get us something a little better like this red line. And then finally we can use something like GPR, Gaussian process regression, which will help you fit where you do have data, make better estimates. And so for that we use PyMC actually, and run that through, and we get a slightly better estimate like that. And then we can tweak with the parameters and all, but after a while we come up with some sort of model like this that takes all three of those stages, combines them together, and gives you a model that looks like that. And that's just for one set of covariates. So they say, well, I think that blood pressure and diet are the biggest factors here. But someone else might say that I think that smoking is the biggest one, and alcohol is a big one. And other people say, well, there's no conclusive effects on alcohol. So we try all these different models. We create a giant ensemble where we run, oftentimes it's thousands of different types of models through all those stages. And what this is showing you is each row is a model, and then we've done selective cross-validation based on what sorts of missingness do we observe in the data. And what happens is as you move across, do more sets of cross-validation, you'll find that you get more and more homogeneity in the rankings of the models, and we use that to choose what's the best ensemble. So we had written this all in Stata about, I guess it was 5 years ago now. And as you can imagine, it was a bit of a mess making thousands and thousands of models run from Stata. So we rewrote it recently in Python. We were able to speed the whole thing up by about 40 times. So we use stats models for the first stage regressions. We rewrote all the space-time smoothing, again in Python, and then we use PyMC for the GPR. And so not only did it make it a lot faster, it made it easy to integrate with an online dashboard. People can just go and run these models, and these can just be epidemiologists who have no idea what, how to write a line of code. So that's been great. It's enabled us to work with these collaborators around the world and get their inputs on, like, I think we should use alcohol in this model or not, and get their input into it. While we were doing this, we've created a generic ensemble model framework that we're hoping can be used for things besides just our types of models, where the basic idea is you generate a universe of models, you set up some sort of cross-validation scheme, run that through, and then it builds ensembles and chooses how to weight the different models relative to each other in an ensemble and produces results. So that's a new thing that we've got. We're still tearing out a few of the things that are really tied into our computing cluster. But if you have any test cases for running this sort of ensemble model and would like to work with us on that, we'd love to come up with some more generic examples of how this could be used. So another big priority area for us is disease modeling of things that aren't killing people, so non-cause of death. And for that, the issue we have is that there's a lot of different measures of disease. So you can count how many people alive right now have this disease. You can count how many people got this disease this year. You can count how many days does the average person have this disease for. You can say, how more likely is this person to die if they have this disease? And we have all these different measures from all sorts of different sources, but they're actually supposed to be somewhat internally consistent. That is, that as more people get the disease, that's the incidence rate, then the prevalence, the total number of people that have it, should go up. But as the case fatality rate, that's how much more likely you are to die if you have the disease, goes up, well, the prevalence is going to go down because a lot of those people that have the disease are dying off. So you need all these things to be internally consistent, but they're measured all independent of each other with different samples, different methodologies, and it just makes for a real mess. But we've gone through and done thousands of studies through giant literature reviews and coded all that data in. And then we need to make it internally consistent. So that's where we have this thing called DisMod, which uses PyMC to do a little meta regression on these. And The idea is that we take the epidemiological data as well as some covariates, we run it through DISMOD, and now we have, just like we had for cause of death, for every single year, country, age, sex, we have estimates of these different characteristics of the disease in the population. So if you haven't seen it before, here's just a generic disease model. The idea is that you have the number of people who are susceptible in one box. That's just anyone who's in the population who doesn't have the disease. Then you have the people who have the condition. So once you get the disease, you move into that other box. Then if the condition kills you, you go into box D, which is those people who died from the condition. And then you can also just die for other reasons that aren't related to the condition. And that happens to both people who have the condition and those who don't. And so then we have all these transition probabilities between them. And we can start looking at how these things should be internally consistent. So what DISMOD does is it applies a series of differential equations to this and then enforces some constraints to make sure they all add up, and then estimates all the different transition probabilities based on that. So there's a whole book on this coming out from my colleague A.B. Flaxman. I think it should be out any day now, actually. So if you're interested in this, an entire book just on these equations. But the general idea is we have here a bunch of data. So on the x-axis, that's age. And then on the y-axis, it's top left is the prevalence. Top right is the incidence. So prevalence is the total number of cases in the population divided by the population, so just the proportion that have it. Incidence is the proportion of people who develop it each year. Then down the bottom we have the relative risk. That's how much more likely you are to die if you have it than if you don't. And then we have duration, which we have actually no data on. And these lines are the horizontal width of a line says what's the age span measured in that survey. So people measure in different age groups. Some people say people who are exactly 50 years old. Some say 50 to 80-year-olds. Some say 50 to 55-year-olds. So we take in all those different ones. And then the vertical line is the uncertainty interval on that. So now we want to find a way to make these all internally consistent, which is where we run DISMOD on it. And it'll come up with a nice set of estimates like this, that if you ran those through the differential equations, fit that formula. Recently, we've also rewritten all of DISMOD. It used to be all PyMC2 based. Now there's a new version. We call it DISMOD AT because it does, instead of just smoothing things over age, it does it across space. So it looks at every country simultaneously, and it does it across time. So it enforces that these equations make sense across all those things. The backend itself was rewritten in C++ using this library called CPPAD, C++ algorithmic differentiation. But then we still use a Python interface and a web dashboard to run it so that anyone can use it. And all this code is online at that address if you have any interest in taking a look at it. The next thing I'll talk about is some of the forecasting work we're doing and some of the simulation tools we've built in order to run that. So the idea of the forecasting project is we want to say, what's the most likely thing to happen in the future, given past trends and whatever information we have? How might that change? So under different scenarios, if smoking goes up, if there's a natural disaster, if there's another great global depression, what would we expect to happen to health in that case? What happens if there's a new HIV vaccine? How would that affect population in 40 years? And the idea behind this is Bill Gates wants to know where to spend his money right now to save the most lives in 2040. So what we do is we generate possible scenarios for every quantity that's in the global burden of disease, and we do it in a internally consistent way that we capture the correlations between everything, such that in a simulation in which blood pressure goes up, well, heart disease and stroke are going to go up as well. And that will be tied into whether sodium consumption went up or not. So we want to simulate all these different trajectories based on what they've done in the past and also their relationships to each other. So to give you a better idea of what I mean by that, here's an example where we've got, for instance, just 4 quantities where we want to look at what's the GDP, so what's the income of the country, tobacco consumption, total death rate, and the population. Well, the best way for us to predict the GDP in next year is going to be to look at GDP in this year. But we also might want to look at, did the population grow or shrink, or maybe it's more, did the percent of the population that's working age change? So as the population gets older and fewer of their people are working age, that's going to hurt their economic growth. Then we might also want to look at what the tobacco rate next year is. So again, this year's tobacco is a great indicator of that. But we also find that as income goes up, that's going to affect your tobacco. So we want to get that correlation in there. Mortality, again, last year's mortality. As income goes up, your mortality rate goes down. And as tobacco goes up, your mortality goes up. And then population is, again, driven by last year's population, how many people died this year. And GDP can affect things like migration or fertility rates. And so we just keep cycling through all these relationships in order to come up with a simulation all the way out that captures all these results. And then we do this tens of thousands of times using draws from the uncertainty distributions of the transition parameters between all these states, the correlations between them, our uncertainty on what they looked like in the past. And so it comes out to this gigantic mess of a directed acyclic graph that we need to evaluate. So how we do that is we start out by just fitting models for each of those boxes, each of those nodes in that graph, based on various different statistical methods we've come up with, which I believe every single one of those is in Python. And then we run it through that simulation, and eventually, once we do that with all of the different uncertainty, just based on the number of floating point numbers, not even really counting all the indices, it's going to be over a petabyte of data, just based on the size of that simulation. So what we've been doing is using PySpark data frames for scheduling and running these. And I'll get a bit into how we're actually doing that in a second. And then eventually we're going to expand this to doing micro simulations as well, which is we're going to include individuals so that you can look at their actual interactions with the healthcare system as they go about their lives. So you can see how often they go to the doctor, how changing, for instance, how often do you screen for colon cancer at the doctor, how was that going to affect death rates in the future. In order to run all this, we've created this tool that we don't have a good name for it yet. I'm open to suggestions. We just call it the simulation builder. And the idea is to be able to run these sorts of giant simulations in a very modular way and in a high performance way. So what we've done is come up with a really modular YAML schema. You just make a little text file, and you can just create that using PyYAML that says what is each node and what. So that's like a quantity, like GDP. And then you say, what is it related to and how? So you say that GDP is influenced by population. And then you can say, what's the formula for this? And you can just define this using SymPy. So you can use basic mathematical expressions, and you can also add in custom functions of your own that operate on NumPy or Pandas type data and run those through as well. And then what the simulation builder does is it creates the DAG from that and determines an execution path. And then when you want to run it, you can, if it's small, you can just run it in NumPy or Pandas, and it'll do it all right on your local machine. And if you have something that's much bigger, like we do, that won't fit, then you can use PySpark. Just give it the DAG, and it'll figure out how to set up the rest. So we've also built a bunch of little tools in Python, like this is using PyCurses, and so you have a little command line interface that you can explore your YAML files, for instance. So for instance, here we've got, we're just looking at GDP per capita is the first thing, the demographic dividend, that's the proportion of the population that works, and GDP. And it says that GDP is dependent on all these different model parameters. And if we look at, for instance, if you would click, hit enter on GDP per capita, it says, well, it differs by D is draw from the uncertainty, T is time, and loc is the location, so the country. And then it says, how do I come up with GDP for a draw, year, and location? GDP per capita, that is. Well, you just take the GDP in that year, draw, and location divided by the population in that year and location. So that's all you have to do is give it an expression like that, and it'll figure out the rest. It'll figure out that, oh, that means I need GDP from the same year and population from the same year in order to calculate this and add that into the DAG. And so once you run that, you can also have it output graphical representations of the DAG. And and it puts it out in a GraphViz format, so we're working on trying to come up with some tools to like visualize that in D3 and make it easier to explore what all is in your simulation. So that's a cool new tool we're working on. We don't have it all on GitHub yet. We're just, again, tearing out some examples, but I expect within a week or so it'll be up there. So if you have any interest, let me know, and I can give you the address for that. The next thing is what we use to optimize these giant models we're fitting. And we've come up with this little tool we call PyMB, Python Model Builder. And we call it that just because it started out as just a Python wrapper for something called Template Model Builder, which is just a C++ library that then itself got wrapped into an R library. So the idea is that we have these models that have, in many cases, thousands of parameters, thousands of random effects that we need to optimize. And a lot of the existing solutions that are built into R just don't work. So the nice thing about TMB is it uses algorithmic differentiation with CPPAD, that module I mentioned before, to really quickly optimize these models. And it also does this neat trick of integrating out any random effects and optimizing with respect to those so that it can do it much more quickly. So it will just return some derivative information as well as likelihood, and you can just pass this to any optimization function, including the built-in SciPy or R optimizer functions. So version 1, it actually uses RPy2, runs an embedded instance of R, which itself is running a bunch of C++ modules. Kind of creaky. It works, but it's a little bit more overhead than we'd like. So we're working now on using Cython to try to wrap up some of those functions from DismodAT, which itself is based on CPPAD, to turn this into a much more generalized function. So you can find that on GitHub now. Again, it's only version 1 that's on there right now, but I'm looking to get version 2 going in the next 4 to 6 weeks. So just a little case study of how this works is there's this mortality forecasting software out of Gary King's group at Harvard that's widely used for trying to predict mortality rates. And so this Yourcast package is written in R and uses a Gibbs sampler to fit it. And it just takes forever to run. It produces great results because I won't get into the model specification over there, but it allows you to put all sorts of priors on your model that really help give good fits, but it's just tragically slow with that Gibbs sampler and often doesn't converge at all. We rewrote it in PyMB, got over 1,000 times speed up, and we're able to add in a lot more different interaction terms and just make the whole model more complex and fit for multiple countries at the same time, for instance. So the last thing I'll show you is just we made it so much faster. This is a real-time IPython widget that lets us run the entire model in about a second and update a plot. So we can select some of the prior parameters in it and really actually get a feel for how the model works, which is something whereas with the R version it took at least half an hour to run and in some cases several days to run. So it's really just improved our workflow and ability to fit these cool models that we think will hopefully lead to results that help make better health policy decisions. So if you got any questions about any of this, or if I went too fast and you missed any of the links, just hit me up via email or let me know after this. Also, I'll just give a quick plug. I just posted a really cool job description yesterday to work on some of that PySpark forecasting work. So it's there if you have any interest on working on that with us. Hey, thanks.
There was a slide where
Which one was that in?
You're trying to compare models in the ensemble. I think it's a lot of this.
This one. Yeah, so that, sorry, I skimmed through that, but the color there shows the rank of the model. And then the rows are sorted based on if you ran 25 different cross-validations, what would their rank be? So in the last column, aside from the in-sample column, that just shows you that fitting your model based on in-sample fit is not a great way to actually come up with what's the best out-of-sample model. But in the last one, it's a smooth gradation between green and red. But if you look in the earlier columns, you see that there's a lot of mixing there, which means that if you only do 1 or 2 cross-validation runs, it'll pick a model that doesn't actually work that well. Yes?
Have you guys done any work looking at modeling violence as a discipline?
Yeah, so we model a lot of outcomes of violence, yes. So under the injuries section, we have both deaths resulting from homicide, suicide, wars, and then we also have a lot of injuries that we look at disability resulting from them over time. And then we have risk factors for things like intimate partner violence and things like that as well. Yes?
So you guys produce a lot of code. Do you have a standard internal process for introducing packages, vetting them internally, releasing them, or is it sort of, hey, you got a great idea, put it on GitHub and we'll figure it out?
So the question is how we deal with all the different code we're producing and try to systematize that. We're working on making a better system for that. It's difficult largely because we come from very much a research, like epidemiologist perspective, most of us. So we're trying to get more and more systematic about that sort of thing. So we have an internal Git repository system, and we're slowly forcing people to use it. And sort of the carrot and stick approach is that if you want to run stuff on the big computing cluster, we're starting to say, well, you have to have it checked into Git. You can't just throw any code on there. And then we're implementing some code review around that as well.
GPUs for accelerating some of the stuff, or is it too much effort?
The question is about GPUs and whether we've used them. We've looked into it a bit. We're thinking of it for some of these micro-simulation studies where we need to have lots of individuals that we simulate over time, and they can all be independent of each other. So I think it could be very useful for that. The issue with some of the big other simulations I showed is that they just have so much data that the GPU RAM is the limiting factor.
The biggest consumer of your forecasts and like historical estimates that you produce, or like who is most consuming that?
Yes, the question, who is the consumers for all this? Yeah, the Gates Foundation is the biggest one and the one who fund most of it. But that's starting to change, where we're working a lot with countries themselves. We're working with NGOs that focus on particular diseases or countries. And we're seeing a lot of uptake. Just basically anyone who holds the purse strings for health money is kind of interested in this work. Yeah.
What's the size of those simulation models?
So the size is, we typically have about 500 different diseases and 20 age groups. We do it over 70 years for 50 risk factors, and we look at about 5 different ways of measuring the outcomes, and then we do about 50,000 draws from the uncertainty estimation. So it comes out to a little over a petabyte of storage for that. We try to work on some short-term things. It's a little bit harder because we, as an organization, we require grants to fund these things, and it's hard to get a quick turnaround on those. But we actually just got a grant for some Ebola work right now.